Hi, this is Brandy with Mana Health Partners, bringing another educational series video about documentation for patient referrals. In the past, there have been some questions about patients being referred out, and I just wanted to clarify a couple of things. So why would you refer a patient out, and the rationale behind that? So the objectives we're going to talk about today are to review the requirements and documentation that you'll need, to understand the documentation requirements that are required under your HPI, to understand documentation requirements under the assessment and plan portion. And then we've got a couple of examples that we can review. We've got one on ortho, one on mental health, and then one on chronic management. So the purpose really is to document a referral to a specialist, a psychiatrist, a therapist, a neurologist, pain management, when no significant workup is performed at the time of the referral. So if we're just referring out and we haven't done anything particular, how do you document that? How do you go about doing that? So requirements for billing. So requirements to billing require a couple of things. First, it requires a face-to-face visit. They can't call you on the phone and say, so-and-so has mouth pain, can they see a dentist? They can say that, but you won't be able to bill for the visit. So in order to bill for the visit, you'll need a face-to-face. The face-to-face has to be medically necessary. So that is you assessing the patient and documenting what interventions were completed, why the referral is needed, why you can't go and extract a tooth. An appropriate history and or exam was performed, and you made the clinical decision to refer, and that counts as your management aspect. So here's an example of an ortho patient. A patient comes in with chronic knee pain. You don't do x-rays, you don't do labs, but you do take a history, you do assess their function, and then you refer to an ortho. You can bill an evaluation and management code as a 99308 as your time, decision-making, and documentation justify it. So you've done the assessment, you've taken the history. What you can't bill for is that referral over the phone or a non-billable encounter where the nurse practitioner only acted as a conduit. So you go in, you see the patient says, I have a sore mouth, I need to see the dentist, and you leave, and that's the extent of it. You don't get to bill for that. So as far as CMS and MAC guidance go, the referral itself is part of the evaluation and management. It's the management part. The evaluation part is what we're going to focus on today, but the management is the referral out. So your documentation of whatever our problem is, and then you made the decision to refer out to whomever the specialist is. And then there's evidence of your clinical reasoning, even if no diagnostics were ordered. So documentation. So chief complaint for this patient that you're referring out to ortho, they have left shoulder pain. Under that, in your subjective, you're going to want, under your HPI, you're going to want either old carts or a description of what's going on. So because it's pain, we're going to want old carts. So we go with onset. When did this happen? Maybe it's been going on for a year and a half, but it's getting progressively worse. And since they've been in the skilled nursing facility over the last 20 days, it's significantly worse. Maybe they're doing more physical therapy, whatever the issue is. The duration, how long it lasts. What are the characteristics? If you're going to define pain, you're going to put a pain scale as well as the description of what kind of pain. Is it aching, throbbing, stabbing, shooting, sharp, radiating, etc. Any aggravating factors, maybe it is therapy that's doing it, range of motion, that sort of thing. And then anything that is relieving factors. It always disturbs me when patients say, I've had a lidoderm patch before and it doesn't work. Sometimes we have to use multiple modalities to treat depending on whatever the symptoms are, to treat that. So maybe it is an anti-inflammatory like ibuprofen alongside a lidoderm patch, alongside some biofreeze at bedtime. That's just an example. Any previous interventions? Have they gone to an ortho before? Have we done anything prior to this? And then what's the impact on their function or their ADLs? So an example of this under the HPI is the patient reports dull, aching pain. So we've quantified that pain in the left shoulder, that's the location, for 3 weeks. That's the duration. Gradually worsening. Pain is aggravated by overhead movement, not relieved by Tylenol, no trauma reported, impacts ability to dress and sleep. So your assessment and plan, your first part of the assessment is going to be your diagnosis. So this diagnosis is pain in the left shoulder. And then your assessment of that is new, worsening, progressive. You have to have some sort of an assessment of that. You could even say pain, 10 out of 10, 9 out of 10, that sort of thing. Aching, stabbing, throbbing. And then your plan is going to be to refer to the specialist and then why. So the rationale behind this one would be refer to orthopedic due to persistent pain, functional limitation, and concern for possible rotator cuff impairment or involvement, referring to orthopedics for further evaluation and imaging. Especially with a rotator cuff, an X-ray is really not going to do it. You're really going to need to look for that MRI to get further information for a rotator cuff. You're going to document, don't forget to document that patient education provided. Why are you not doing anything at this point? Why are you not getting anything? Well, you can explain to them. An X-ray won't really show what I think is the problem based on the assessment that I did. And so I'm thinking maybe it's a rotator cuff issue. And so I'm going to refer you out to ortho. And then after the patient gets back, so you're going to make the referral. And then when the patient gets back, you're going to see the patient several days after, making sure that there is no follow-up appointment, there are no labs, there are no diagnostics, there are no new orders that might have been missed. You want to review what they said. You were smart enough to send them to a referral. Now you want to know what the specialist reported back to you. And then your time or MDM. It's based on time or number of problems, data, and risk. So you have to do 2 out of the 3 to get the medical decision making. So problems, data reviewed, and risk. So we have our problem, we have pain, we have data reviewed, 0, maybe a progress note, but that doesn't fit. You can definitely put collaboration, that counts. And then the risk, we're literally not putting anything into place except for a referral. So, and you're not going to take a lot of time working this patient up. So you're going to be documenting something like a 99308 for this. Of note, there are certain ICD-10 codes that cannot be billed as primary. So those would be Z codes, they would be T codes, they would be L codes, and some R codes, which would be symptom management or symptoms. So make sure that whatever ICD-10 code you're using can be utilized as a primary. I'm not sure about pain in the left shoulder, but you're going to have to check, because if that is literally what this whole entire note is based on, and you add nothing else of importance that would quantify medical decision making or taking more than 15 minutes worth of evaluation, that claim is going to get denied. So I've got one here for mental health referral. So let's say the patient has depression, anxiety, behaviors, mania. Some of that the patient might report, some of that the nursing might report, some of that the family might report. So obviously the patient isn't going to report that they're manic, but the nurses may say they haven't slept for 3 days and they're spinning around and they can't stop talking. So maybe we're getting our information from multiple sources, but a chief complaint is the problem and the title of the story. So we would use that. Same thing with behaviors. So your subjective assessment under that first HPI is the patient or the nurse or the family request referral for a psych eval, medication management, therapy, etc. So whatever we're requesting. And then whatever the symptoms are, how long have they been going on? What are the severity of them? What triggers them? What makes them worse? Sometimes when patients are having behaviors, they just want to be left alone. That doesn't mean isolate them, but if they want to be in their room and they want to be alone and that's their preference, then that will help decrease those triggers. Use patient's own words if possible. If not, then you can use nursing reports or family reports. The impact on daily function and safety. So this could be that they're not able to sit still and sit down and eat, or that they're pacing constantly. It could be that they won't leave their room, that they are self-isolating, and that they cry half the day. Any past psychiatric history, if you know it, medications tried, declined, ineffective, and then patient requests. I love it when they always text me and say, so-and-so is requesting Ativan multiple times a day or requesting Xanax, had it home for many years. So they know the drugs by name and they're asking for them by name. So here's an example. Reports increased anxiety over the past 3 months, especially in the morning. Difficulty concentrating on work. So whether that work is going to activities, playing bingo, going to therapy, whatever they're working on, they cannot functionally do that because of their lack of concentration. Denies suicidal ideation, feels current SSRI is not effective, requests evaluation by a psychiatrist, or that could be referring to a psychiatrist. So your objective assessment, so that is your physical exam, your mental status. So make sure you're putting that under neurological and under psych if they're having behaviors. Vitals, obviously, appearance, behavior, affect, speech, thought process, all of that gets listed under that psych aspect of the physical exam. If you've done any screening tools, you can put that either under subjective, under a little blip, or there you could utilize a section underneath and just handwrite that below your physical exam. So any lab results that are available, if you've got a TSH of 20 and normal is 0.5 to 5.5, we've got a TSH problem. So we need to be looking at that medically and making sure that we've ruled out medical causes. And so an example of that would be affect anxious, speech rate normal, thought content logical, PHQ-9 is 15, GAD-7 is 17, no psychosis noted, alert and oriented times 4. So right now we can see that the patient has significant depression and significant anxiety as well. So under the assessment part, we're going to start with our ICD-10. If we have a symptom, great. If we have a diagnosis, even better. So we want to, again, code to the highest ability that we can. And so if we have a diagnosis of dementia, depression, anxiety, we're going to use that versus complaints of anxious features or exhibiting anxious features, that sort of thing. So state their status of the diagnosis. Is it stable? Is it worsening? Are they in partial remission? If no formal diagnosis, use an R code. Again, like I know for a fact, suicidal ideation cannot be an initial or primary diagnosis. So it needs to come under something else. So make sure you're checking what your primary diagnosis is or your first ICD-10. Note lack of prior psychiatric workup if relevant. Patients newly admitted to facility or patient reports no psychiatric history. A new admit will refer. So here's an example. You've got generalized anxiety disorder. You've got moderate, suboptimally controlled on current SSRI, considered to rule out ADHD, no prior formal psychiatric evaluation. So I'm not going to get into ADHD, but ADHD looks a lot like anxiety, and depression looks a lot like bipolar. Mixing the two of them up, either one of those, could end up with very bad outcomes. So that's why you always want to defer to your psychiatric mental health nurse practitioner. Your plan is referral made to PMHNP, psychiatrist, psychologist, whatever we're doing. Educated on the referral process. You can tell them the nurse practitioner will be in here on Thursday or on Tuesday or in one day or tomorrow. I will let her know that you need to be seen. Any urgent safety measures that are documented, continue or hold current meds, and then follow up with you after, and we usually say 3 to 5 days, because when we switch a medication, we're looking for side effects and we're looking for effectiveness, if it's a sedative, hypnotic, or an anxiolytic, and we're looking for those suicidal ideations if it's an antidepressant. So some of those things we need to follow up on sooner than 4 weeks. So this example is referral to psychiatrist for medication management and diagnostic clarification. Continue Zoloft at 50, patient advised to follow up in 4 weeks or sooner if symptoms worsened, and provided crisis hotline for safety. So I would always put, if you're worried about a patient, you should be talking to the DON. If you're putting it in your notes that the patient could potentially be in crisis, make sure you let the DON know and document that. If you want them on one-on-one, and then the psych NP can come in and take them off of that. Now, we don't put everyone on a suicidal watch or a one-on-one, but if you've got a patient that knows they want to die and they're going to start hoarding their pills and they've got a plan, that's an important thing. And then your add-on again is safety and capacity. So if they refuse a referral, so you go in, they're having behaviors, you talk to them and they get angry and agitated. I'm not crazy. I'm not going to go see a therapist. I'm not taking any medications. We're going to look at that from their capacity. And then if there's any suicidal or homicidal ideations, any psychosis, we're going to document that. We're going to document the support system, the plan for safety, and whether we needed to call and get a Baker Act for the patient. So a referral visit for like a chronic condition. So let's say I'm just going to throw out on this one diabetes. Follow up for diabetes, referred to endocrinologist for advanced management, subjective. Symptom status, improved, worsening, stable. So symptoms, so that's your blood glucose, that's your A1C. Is it worse? Is it better? Treatment adherence. So if they're on a no concentrated sweet diet and yet have donuts, chips, and a whole slew of treats on the right-hand side, and then non-sugar-free drinks on the left side with some juices and some Gatorade with sugar. That's what we need to document. It's not that we're not trying to control their blood glucoses, it's that they're not being compliant. Any side effects from meds or interventions, those would specifically be your GLP-1s if you're having adverse effects related to that, any lifestyle factors, and any specialist requests or questions that they have. So here's an example of your subjective. Patient reports stable blood sugars, but new onset leg swelling and fatigue, denies chest pain or shortness of breath, concerned about kidney function, taking metformin and insulin as prescribed following low sodium diet. And so maybe in this one, based on this, you would be follow up with nephrology. So follow up for chronic kidney disease with nephrologist. So objective, you're going to, again, have your vital signs. If you've got any labs, anything of pertinent, any diagnostics, and then your physical findings, edema, breath sounds, and then your example of what your objective, 220 pounds, trace edema. So this is your physical assessment that you're going to add that to. Your assessment is going to start off with your ICD-10 code. So make sure that it's at the highest specificity. So you can see 3 examples down here for this one patient: type 2 diabetes with chronic kidney disease stage 3, and hypertension with chronic kidney disease. So we've coded to the highest specificity. Their type 2 is moderately controlled, but their renal functioning is worsening and their hypertension is not at goal. So our plan is going to be to refer who, why, and what is the urgency. If you have a GFR of 13, it might be more urgent than if you have a GFR of 20, which is still important, versus a GFR of 40. So emergency, urgency, interim management plan. So we may have to hold some diuretics here, regardless of their edema, depending on their GFR. We're going to obtain labs if we need to, lifestyle education, what the specialist is going to address, return to clinic timeframe. So when are you going to see them back? And then medication adjustments. So here's an example. Referred to nephrology for evaluation of declining renal function and medication optimization, continue lisinopril, insulin, and metformin, recheck the BMP in urinalysis in 2 weeks, educated on fluid intake, salt restriction, and then follow up 4 weeks after the post-nephrology appointment. I would almost say 4 days. And then 4 weeks after that, I would make sure of what the nephrologist said and what your plan is going to be. So when we write what should not be forgotten, I love this screen because this helps remind us that next year, next month, in 2 years, we may forget why we had this certain patient and why the plan was as such. So please make sure that you write down what needs to be documented on. So should there be a request for chart records or litigation or ACA, and they come in and they want to know why you did a certain thing, that you've got it written down so you don't forget. If you have any questions, my information is here. You're welcome to call me anytime, text, email. But I hope this helps a little bit with referrals out. Remember, please try to add an additional diagnoses to make sure that it meets the criteria for what we're billing for. Referring out, if you're just going to refer out, make sure you do that thorough assessment and the thorough HPI as well as your plan. I hope you got something out of today. I hope it was productive. And if you have any questions, feel free to call. Have a great day.